You know that feeling? When you're trying to wrap your head around something really complex, maybe like mental health stuff, and you just feel lost in all the information.
Oh, totally. It can be overwhelming.
Exactly. So that's why we're here. For this deep dive, think of us as guides. We're navigating through the specific information you sent over.
Right. And today, we're focusing specifically on trauma and stressor-related disorders. Using your sources, we'll look at reactive attachment disorder,
Okay.
disinhibited social engagement disorder,
Oh.
PTSD, posttraumatic stress disorder, obviously,
Yeah.
acute stress disorder, and adjustment disorders.
Right.
Get a clearer picture of those.
Yeah, our mission here is basically to pull out the key things, the main characteristics, the criteria for diagnosis, and importantly, how these things differ.
Exactly. Give you a solid overview, highlight the critical stuff so you feel informed, not snowed under.
Perfect. So let's start with reactive attachment disorder. What's the absolute core feature there?
Well, the main thing is this consistent pattern where a young child is inhibited, emotionally withdrawn, specifically towards their adult caregivers.
So it's not just shyness, it's really about that connection, or lack of it, with the main adults in their life.
Precisely. And it shows up in a few key ways, like the child often doesn't seek comfort when they're upset. And even if comfort is offered, they don't really respond to it. There's also, like, minimal social and emotional back and forth,
Okay, yeah.
limited positive feelings being shown. And sometimes you see these episodes of unexplained irritability or sadness or fearfulness,
Yeah.
again, specifically with caregivers.
Wow, that sounds incredibly tough for everyone involved. What kind of background leads to this? What's the cause?
The diagnosis pinpoints extreme insufficient care. And that's not just, having a bad day as a parent. It's significant.
Right.
It could be a persistent failure to meet the child's basic emotional needs, comfort, stimulation, affection, that kind of thing.
Yeah.
Or maybe repeated changes in primary caregivers. Think lots of foster homes, maybe. That really disrupts forming stable bonds.
Makes sense.
And finally, being raised in settings that just don't allow for forming those selective attachments. Like maybe an institution with really high child-to-staff ratios.
So a real breakdown in that early bonding. Is there an age limit or time frame for this diagnosis?
Yeah, the symptoms need to show up before the child is 5 years old. And crucially, the child has to have a developmental age of at least 9 months.
Okay, got it. That clarifies reactive attachment disorder. Now, the next one you mentioned, disinhibited social engagement disorder. The name sounds, well, almost the opposite.
It really is quite different in presentation, where
Yeah.
reactive attachment is withdrawal. Disinhibited social engagement involves this pattern of being overly familiar and interacting inappropriately with strangers.
Inappropriately how? Like, what does that actually look like?
Well, imagine a young kid showing little or no hesitation, walking up to and interacting with a complete stranger.
Oh.
Maybe being overly familiar, physically even, in a way that's not typical for their age with someone they just met. Another thing is not really checking back with their caregiver after wandering off.
Right.
And maybe the most worrying, being willing to go off with an unfamiliar adult with, like, minimal hesitation.
Wow, yeah, that sounds very risky. What's the background there? Is it the same kind of early experience?
Interestingly, yes. The presumed cause is identical. Extreme insufficient care. Same criteria, unmet emotional needs, multiple caregiver changes, or those unusual rearing environments limiting attachment.
Huh. So the exact same kind of early adversity can lead to either withdrawal or this kind of indiscriminate friendliness.
It seems so. Two very different outward behaviors stemming from that similar lack of stable nurturing care early on.
Fascinating. And the age requirement, same 9-month developmental minimum.
Yes, same thing. Developmental age of at least 9 months.
All right. Let's shift gears to one that many people have probably heard of. PTSD. Post-traumatic stress disorder. This one obviously starts with a specific event, right? A trigger.
Absolutely. PTSD follows exposure to actual or threatened death,
Yeah.
serious injury, or sexual violence.
And how does that exposure happen? Can it be indirect?
It can. So, number one is directly experiencing the traumatic event yourself.
Okay.
2, witnessing it in person, happening to someone else.
Right.
3, learning that the traumatic event happened to a close family member or a close friend. But in cases of death or threatened death, the event must have been violent or accidental.
Okay, so finding out a relative died of natural causes wouldn't typically qualify.
Correct. And 4th, experiencing repeated or extreme exposure to aversive details of the event. Think first responders collecting human remains or police officers repeatedly exposed to details of child abuse.
Gotcha. But there's a note about media, right?
Yes, important clarification. Exposure through electronic media, television, movies, or pictures generally doesn't count unless that exposure is work-related.
Right, so seeing news coverage isn't the same as being a war correspondent on the ground. Okay, so after that exposure, what symptoms emerge?
Well, they fall into several clusters. First, you have intrusion symptoms. The trauma keeps invading their thoughts.
How so?
This could be recurrent, involuntary, and distressing memories, or distressing dreams about the event. In kids, this might look like repetitive play showing themes of the trauma.
Okay.
Also, dissociative reactions like flashbacks, where it feels like the event is happening again. Again, kids might show this through reenactment in play.
Mhm.
And then there's intense psychological distress or strong physical reactions when exposed to things that remind them of the event. You need at least one of these intrusion symptoms.
That sounds awful, just constantly being pulled back into it. What else?
Avoidance. That's the next big cluster. Persistent effort to avoid distressing memories, thoughts, or feelings connected to the event.
Mm-hmm.
Or avoidance of external reminders, people, places, conversations, activities, objects, situations that trigger those memories or feelings. Need at least one type of avoidance.
So, trying hard to push it away or stay away from triggers, does it affect mood and thinking more generally?
Definitely. That's the third cluster. Negative alterations in cognitions and mood.
Yeah.
You need at least two symptoms from this list.
Okay, what's on the list?
Things like being unable to remember an important part of the trauma, persistent negative beliefs about oneself, others, or the world, like I'm bad or the world is dangerous.
Right.
Distorted thoughts about the cause or consequences leading to blaming self or others. Markedly diminished interest in significant activities.
Mm-hmm.
Feelings of detachment or estrangement from others. And a persistent inability to experience positive emotions, happiness, satisfaction, loving feelings.
Wow. It really can change someone's whole worldview. What's the final cluster?
Marked alterations in arousal and reactivity, again, need at least two of these.
Such as?
Irritable behavior, angry outbursts with little provocation, reckless or self-destructive behavior, hypervigilance, being constantly on guard,
Yeah.
an exaggerated startle response, problems with concentration, and sleep disturbance, trouble falling or staying asleep.
Okay, that's a lot. You mentioned earlier that the criteria are slightly different for young kids, 6 and under.
Right. For that age group, the exposure criteria includes experiencing or witnessing trauma involving a caregiver or learning about a trauma happening to a caregiver.
Okay.
Intrusion symptoms often show up as that repetitive play we talked about. And importantly, they only need one symptom that represents either avoidance or negative changes in cognition mood, not necessarily both clusters.
Ah, okay. That's a key difference.
The arousal symptoms are pretty similar, though: irritability, hypervigilance, sleep problems.
And for any PTSD diagnosis, regardless of age, there's some general rules.
Yes, the symptoms have to last for more than 1 month,
Okay, duration matters.
and they must cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Can't just have the symptoms, they have to be causing real problems.
Makes sense. And there were specifiers mentioned.
Yeah, two main ones. One is with dissociative symptoms, which means the person also experiences persistent or recurrent depersonalization, feeling detached from oneself, or derealization, feeling like surroundings aren't real.
Okay.
The other is with delayed expression. That means the full criteria aren't met until at least 6 months after the event, although some symptoms might have started earlier.
Got it. So PTSD is clearly serious. What about treatment? What's considered the go-to?
Well, the treatment of choice is generally comprehensive cognitive behavioral therapy, CBT.
Okay.
This often includes exposure therapy, carefully and safely confronting trauma memories and triggers, plus cognitive restructuring, which helps challenge those negative thought patterns.
Right. The world is dangerous type thought.
Exactly. And anxiety management techniques, learning skills to cope.
Are medications used?
Sometimes SSRIs, selective serotonin reuptake inhibitors, common antidepressants, are used. They can help with comorbid depression or anxiety and might reduce some PTSD symptoms. But there's a high risk of relapse if the medication is stopped. Therapy addresses the underlying issues more directly.
What about other things people sometimes hear about, like CISD, Critical Incident Stress Debriefing?
Ah, yes. CISD is actually quite controversial. It's that immediate group debriefing after an event. Some research suggests it might not be helpful and could potentially even make things worse for some people.
Oh, really? Okay. And EMDR, eye movement desensitization and reprocessing.
EMDR has shown some positive results, but the current thinking is that the benefits probably come more from the exposure element, revisiting the trauma memory and other nonspecific therapy factors, rather than the eye movements themselves being the uh, critical ingredient.
Interesting. So the exposure component seems key across different approaches. Okay, moving on. Acute stress disorder. Sounds related to PTSD.
Very closely related. The trigger is identical exposure to actual or threatened death, serious injury, or sexual violation through those same four pathways: direct experience, witnessing, learning about it happening to someone close, or repeated extreme exposure.
So, same starting point. What's the difference then?
The main differences are the symptom count and the duration. For acute stress disorder, you need at least 9 symptoms total from any of the 5 categories we talked about for PTSD: intrusion, negative mood, dissociation, avoidance, and arousal.
9 total from any category. I
All
got
right. And crucially, the duration is different. Symptoms last from 3 days up to 1 month after the trauma.
So it's that immediate short-term reaction period.
Exactly. If the symptoms last longer than a month and meet PTSD criteria, the diagnosis would typically change to PTSD.
Got it. So time frame is the big differentiator. And like PTSD, the symptoms have to cause distress or impairment.
Yes, absolutely. Clinically significant distress or impairment in functioning is still required.
Okay. Last one on our list, adjustment disorders. This sounds like it might apply to less extreme stressors.
Yes, that's generally true. Adjustment disorders involve emotional or behavioral symptoms popping up in response to one or more identifiable psychosocial stressors.
Mhm.
And the key is these symptoms begin within 3 months of the stressor starting.
What kinds of stressors are we talking about? Like losing a job, relationship ending?
Exactly. Could be job loss, relationship problems, academic failure, moving, even a medical illness. It's a broader range than the life-threatening events for PTSD or acute stress.
So the stressor itself might not be traumatic in the same way, but the reaction is still significant.
Right. The defining feature isn't just having a stressor, it's the clinical significance of the reaction.
And what makes it clinically significant?
2 things. You need one or both. Marked distress that is way out of proportion to the severity or intensity of the stressor, considering the context and culture.
Okay.
And double paired significant impairment in social, occupational, or other important areas of functioning, like someone stops going to work or isolates themselves completely after a breakup.
So it's really about the impact on the person's life. How long do these symptoms typically last?
The rule is that once the stressor or its consequences are gone, the symptoms should remit within another 6 months. But there's an important exclusion. This diagnosis isn't used for normal bereavement after the death of a loved one. Grief is its own process.
Right, that makes sense. Are there different types depending on the symptoms?
Yes, there are specifiers.
Yeah.
You can have adjustment disorder with depressed mood, with anxiety, with mixed anxiety and depressed mood,
Okay.
with disturbance of conduct like acting out, rule breaking,
Uh-huh.
with mixed disturbance of emotions and conduct, or just unspecified if it doesn't fit neatly.
Wow, okay. We've really covered a lot of ground here, from attachment issues rooted in early care, through the intense impact of trauma and PTSD and acute stress, to these reactions to other life stressors and adjustment disorders.
Yeah, it's quite a spectrum.
And it seems like telling them apart differential diagnosis is super important. The sources mentioned a study tip about that.
Absolutely critical.
Yeah.
You really need to distinguish between conditions, like telling agoraphobia, fear of inescapable situations, apart from social phobia, fear of negative judgment, or distinguishing OCD with those intrusive thoughts and compulsions from OCPD, obsessive-compulsive personality disorder, which is more about a pervasive pattern of perfectionism and control.
Yeah, subtle but important differences.
And knowing when anxiety crosses the line from normal worry into something like generalized anxiety disorder, and, as we hammered home, that duration difference between acute stress disorder and PTSD.
That time window is key. And the tip also mentioned treatment approaches varying.
Right. It highlighted that for many anxiety disorders, agoraphobia, specific phobias, social phobia, OCD exposure therapy is often a core component, gradually facing the feared thing.
Makes sense.
Whereas for PTSD and generalized anxiety disorder, it's usually a broader, multi-component CBT approach. Still includes exposure, but also hits cognitive restructuring, coping skills, that kind of thing.
This has been incredibly helpful, honestly, really mapping out these different trauma and stressor-related disorders, their features, how they relate, how they differ. It brings a lot of clarity.
Good, good.
I really hope that for you listening in, maybe some things clicked. You know, those little aha moments about why certain criteria exist or how different people might react differently to stress or trauma.
Yeah, hopefully it broadens the understanding, not just for clinical diagnoses, but how we think about these things in general, maybe for ourselves or people we know.
Absolutely. It affects so many people.
Yeah.
So as you digest all this, here's something to maybe chew on. Given this whole spectrum of responses we've talked about, from attachment issues to trauma reactions to
Right.
adjustment difficulties, what are the bigger implications for how we offer support, how we show up with understanding for the people around us dealing with this stuff?